Section 7 deals with pediatrics and adult spine. First part is pediatric spine. Three common pediatric spine problems are pain, deformity, and neurological abnormalities. Differential diagnosis of pediatric back pain involves number 1, mechanical problem, number 2, developmental, number 3, inflammatory, number 4, neoplastic, and number 5, conversion reaction. Conditions to look for in pediatric back pain are Scheuermann's disease, spondylolisthesis, and infection. Spondylolisthesis and spondylolisthesis are the most common causes of back pain in children. So three conditions we need to look here: Scheuermann's disease, spondylolisthesis, and infection. Treatment of pediatric spine infection is immobilization and antibiotics. Occasionally, surgical drainage is indicated for spinal infection. Let's look into spine deformities in pediatric age group. Pediatric spinal deformities can be scoliosis, kyphosis, or kyphoscoliosis. Let's look into scoliosis. Two main groups are postural scoliosis or structural scoliosis. More than 10 degrees of structural lateral curve is scoliosis. Anatomical classification of scoliosis depends on the apex of the curve. Apex between T2 to T11 is thoracic. Apex between T12 to L1 is thoracolumbar. And if apex of the curve between L2 to L4 is a lumbar curve. Structural scoliosis is again classified into number 1, idiopathic, number 2, congenital, number 3, neuromuscular, number 4, miscellaneous group. Congenital scoliosis is classified by McKeown into failure of formation, failure of segmentation, and mixed variety. Number 1, failure of formation. Complete like hemivertebra, which can be fully segmented, semi-segmented, or non-segmented, or it can be incarcerated or non-incarcerated. Incomplete or partial failure of formation can be wedge vertebra or butterfly vertebra. Second group is failure of segmentation, which can be unilateral bar or bilateral bar, also called block vertebra. Number 3, third category, which is mixed variety. Idiopathic scoliosis is classified according to the age at diagnosis. Number 1, infantile if diagnosed before the age of 1. 2, juvenile if detected between 4 and 9 years of age. Third, adolescent idiopathic scoliosis if detected after the age of 10 years. Neuromuscular scoliosis is subclassified into neuropathic, myopathic, neurofibromatosis, or mesenchymal. Common causes of neuropathic scoliosis are cerebral palsy, spinocerebellar degeneration, spinal cord problems like myelomeningocele and syringomyelia, spinal cord tumors or trauma, lower motor neuron problems like poliomyelitis, spinal muscular atrophy, traumatic or progressive neurologic disorders. B. Common causes of myopathic scoliosis are arthrogryposis, muscular dystrophy, or myotonia. C. Neurofibromatosis. And D. Common mesenchymal disorders causing scoliosis are Marfan's, Ehlers-Danlos syndrome, or homocystinuria. Miscellaneous group causing scoliosis include scoliosis due to post-laminectomy or fracture dislocations. Let's look into idiopathic scoliosis. Most common curve is adolescent idiopathic scoliosis. In infantile idiopathic scoliosis, it's important to rule out other conditions, especially spinal cord anomalies and neuromuscular disorders. Currently, it's believed that significant portion of infantile idiopathic scoliosis will resolve and there is a decline in overall incidence of infantile curves. Infantile idiopathic scoliosis has higher association with congenital heart diseases, developmental dysplasias of the hip, breech delivery, older mother, inguinal hernia, spinal cord anomalies, and neuromuscular disorders. In contrast to idiopathic adolescent scoliosis, in infantile variety, males are more commonly affected, and thoracic curve tends to be convex to the left side rather than right in adolescent scoliosis. Measurements of curves are done by using rib vertebral angle difference, RVAD, or Cobb's angle. All infantile scoliosis will need MRI scan to rule out spinal dysraphism. Serial body casting is still the mainstay of treatment in infantile idiopathic scoliosis. Curves more than 40 degrees of Cobb's angle and greater than 20 degrees of RVAD are likely to deteriorate without treatment. Juvenile idiopathic scoliosis is most common in females. Thoracic curve can be both left or right thoracic curves in juvenile idiopathic. Lumbar curves are very rare. About 70% of juvenile idiopathic curves progress and will need some form of treatment, and 50% of them will require surgery. MRI scan is a must to rule out intraspinal pathology in this age group. Curves more than 40 to 45 degrees will progress and will need surgical intervention. Types of surgery differ depending on the type of curve. Options are posterior fusion, anterior fusion, anterior and posterior fusion with or without instrumentation in infantile as well as juvenile idiopathic scoliosis. Crankshaft phenomena is continued anterior growth following posterior fusion alone, which is a possible complication in juvenile as well as infantile idiopathic scoliosis. Winter has presented a formula for determining potential loss of axial growth after spinal fusion, which is 0.07 multiplied by number of segments fused multiplied by number of years of growth left in centimeters. In adolescent idiopathic scoliosis, right thoracic curve is most common, which is 90%. Next common adolescent idiopathic curve is double major curve, which is right thoracic and left lumbar. Third most common idiopathic adolescent curve is thoracolumbar and lumbar, and lastly double thoracic curve. Left thoracic pattern of adolescent idiopathic curve has relatively higher incidence of intraspinal anomalies such as syringomyelia and needs MRI scan. Risk factors for curve progression in adolescents are 1. Younger patient, 2. Premenarche female, 3. Lower riser grade at curve detection, 4. Large curve, 5. Thoracic hypokyphosis. Boston type of orthosis is an underarm orthosis and is commonly used brace for adolescent thoracic idiopathic scoliosis. There is good evidence in the literature to suggest that braces may not be of much help. If the curve is greater than 40 degrees, it commonly progresses 1 to 2 degrees per year even after skeletal maturity. Curves over 50 degrees often need surgical intervention. MRI scan in adolescent idiopathic scoliosis is somewhat controversial, but atypical curve like left thoracic curve will need MRI assessment. Double major curve has thoracic and lumbar curves of equal structural characteristics. King has classified adolescent idiopathic thoracic scoliosis into 5 groups. King 1, double curve, lumbar curve is more structural. King 2, double curve, thoracic curve is more structural. King 3, right thoracic curve. King 4, long right thoracic curve with lower apex situated between T8 to T10. L4 is the stable vertebra in King type 4. King 5, double thoracic curve, proximal left and main right curve. In congenital scoliosis, lateral curvature of spine is secondary to the developmental vertebral anomaly, producing imbalance of the longitudinal growth. Hallmark here is vertebral anomaly in congenital scoliosis. Very high incidence of intraspinal anomalies are associated with congenital scoliosis. MRI is essential. Associated lesions can be diastomatomyelia, diplomyelia, tethered spinal cord, syringomyelia, or low-lying conus. Skin abnormalities like hairy patch or dimple in the midline is a helpful clue. Neurological assessment is essential. Bracing has a very minor role to play here. Surgical treatment is indicated only when the non-operative treatment has failed. Options available are posterior in situ fusion or combined posterior hemiarthrodesis and anterior hemiepiphysiodesis to arrest growth on the convex side. Neuromuscular scoliosis typically has long C-type sweeping curves that involve almost entire thoracic and lumbar spine extending from the neck to the pelvis, with the sacrum and pelvis being a part of the curve. Treatment of neuromuscular scoliosis is either non-operative, bracing, wheelchair modification, or operative spinal fusion with instrumentation. Operative goals are to have a balanced spine, head centered over a level pelvis with fairly normalized sagittal plane spinal anatomy. Friedreich's ataxia is the most common hereditary progressive spinocerebellar degenerative disease. This has got prevalence of scoliosis very close to 100%. Neurofibromatosis. 10 to 40% of neurofibromatosis patients will develop a spinal deformity. Types of scoliosis can be dystrophic or non-dystrophic in neurofibromatosis. Pseudoarthrosis after spinal fusion is a major problem in neurofibromatosis. In Marfan syndrome, incidence of scoliosis is between 40 to 75%. Pediatric kyphosis. Normal regional alignment of the cervical lordosis is minus 30 degrees. Thoracic kyphosis is plus 45 degrees. Lumbar lordosis is minus 60 degrees. Classification of kyphosis is again divided into 4 main types. Number 1, postural kyphosis. Number 2, compensatory due to fixed flexion deformity of the hip. Number 3, structural kyphosis, which is subclassified as A, degenerative or osteoporosis, B, inflammatory due to Scheuermann's disease or ankylosing spondylitis, or C, post-traumatic. Number 4 is congenital, which can be failure of segmentation or Calvey's disease. Up to 90% of thoracolumbar kyphosis in a chondroplastic patient improve without specific treatment. Kyphosis with vertebral body wedging more than 40 degrees in a child over 5 to 6 years in a chondroplastic patient do not spontaneously correct. Scheuermann's kyphosis incidence is 0.5 to 8% in normal population. Males more commonly affected. Etiology is unknown. Possible theories behind Scheuermann's kyphosis are: 1, aseptic necrosis of the ring epiphysis; 2, abnormal endochondral ossification; 3, mechanical growth deficiency; and 4, genetic transmission. 3 forms are seen. 1, the commonest is thoracic Scheuermann's. 2, less common is thoracolumbar Scheuermann's. And 3, the least common is lumbar Scheuermann. Radiological criteria for diagnosis: number 1, hyperkyphosis greater than 40 degrees. Number 2, irregular upper and lower vertebral end plates. Number 3, Sorson's criteria is wedging of 5 degrees or more in 3 consecutive vertebrae. These criteria mainly apply to thoracic and thoracolumbar kyphosis. Treatment is usually conservative. Surgery may be considered if kyphosis angle is more than 75 degrees. Two most common indications for surgical intervention in Sherman's are pain and cosmetic appearance. Post-laminectomy kyphosis, a few words to remember. Number 1, age. Younger the age at laminectomy, more likely to get kyphosis. 2, anatomical level. Upper thoracic and cervical regions are more likely to produce kyphotic deformities compared to lumbar laminectomies. Best way to manage post-laminectomy spinal deformity is prevention, thereby preserving facet joints during laminectomy. Spondylolisthesis is another cause of kyphosis. Wilsey, Newman and McNabb, mainly called Wilsey's classification of spondylolisthesis. Wilsey has classified spondylolisthesis into 5 groups. Number 1, dysplastic type due to congenital abnormalities of the upper sacrum. Number 2, isthmic due to abnormal pars interarticularis, which is again subclassified as A, isthmic or lytic, B, isthmic due to elongated pars, and C, acute fracture of the pars. Number 3, degenerative. Number 4, traumatic fractures not involving pars. Number 5, pathologic due to underlying diseases. In pediatric age group, Wilsey's type 1 dysplastic and type 2 isthmic spondylolisthesis are seen. 80% of isthmic spondylolisthesis occur at L5, S1. L4, 5 is the next common level to be involved. Meyer-Ding classification is based on the percentage of slip. Grade 1 to grade 4, 25, 50, 70 and 100% slip respectively. Grade 5 is spondyloptosis. Slip angle is the angle of lumbosacral sagittal alignment. Normally, L5 S1 disc has 25 to 30 degrees of lordosis. Normal slip angle is negative. Risk factors for slip progression are younger age, female sex, spina bifida, wedging of L5 vertebra, rounding of anterior sacral dome, and hyperlordosis. Surgical treatment is recommended for all slips greater than 50% and 25% slips if they are symptomatic. Standard operative procedure is bilateral allotransverse fusion. Controversies in the treatment of spondylolisthesis are: number 1, whether to reduce the slip or not to reduce the slip. Number 2, whether to decompress the nerve root or not to decompress the nerve root. If the nerve root symptoms are present, it is logical to decompress the nerve. Number 3, whether one-level fusion or multi-level fusions. Number 4 is whether in situ fusion or reduction, instrumentation and fusion. Second part is on adult spine in this chapter. Fractures and dislocations of the adult spine. Types of injury can be either blunt trauma or penetrating trauma like gunshot injuries to the spine. Anatomical division for descriptive purposes are: number 1, upper cervical injuries involving occipit to C2. Subaxial, number 2, subaxial cervical injuries involving C2 to C7. Number 3, thoracolumbar injuries. And number 4, sacral injuries. Initial management involves immobilization and transport. Medical management after the NASCIS trial of spinal cord injury is methylprednisolone administered within 8 hours of the injury. Dennis has described 3 columns, and the classification based on these 3 columns is: number 1, compression fracture is the fracture of the anterior column. Number 2, burst fracture when anterior and middle columns are involved. Sometimes middle column encroaching and protruding into the spinal canal. Number 3, flexion distraction injury or seat belt injury distracts middle and posterior columns. Number 4, fracture dislocation involves all three columns in compression, distraction, rotation and or shear. Neurological injuries can be upper motor neuron injuries, conus medullaris or cauda equina, which is a lower motor neuron injury. Spinal cord injuries can be complete or incomplete. Incomplete spinal cord injuries are: 1. Anterior cord syndrome will have motor paralysis with preservation of sensation. 2. Posterior cord syndrome, which is very rare. 3. Central cord syndrome, where upper limbs are more severely affected than lower limbs. 4. Brown Sequard syndrome with ipsilateral motor paralysis and loss of position sense and contralateral loss of pain and temperature sensation. Number 5. Conus medullaris is combination of sacral upper motor neuron and sacral or lumbar root injuries, usually at the level of L1-2. Number 6. Cauda equina injuries are below L2 vertebral levels, most commonly involve bowel and bladder function. Frankel classification or American Spinal Injury Association impairment scale of spinal cord injury classification is: A. Complete spinal cord injury with no motor or sensory function. B. Incomplete injury with intact sensory but no motor function. C. Incomplete injury with some motor function which is not useful below the level of injury. D. Incomplete injury with useful motor function below the level of injury, and grade E is normal spinal cord. Asia. Standard neurological assessment spinal cord injury for motor function are: C5 for elbow flexion, C6 for wrist extension, C7 elbow extension, C8 finger flexion, DIP of middle finger flexion, T1 for little finger abduction, L2 hip flexion, L3 knee extension, L4 ankle dorsiflexion, L5 long toe extension or extensor hallucis longus, S1 for ankle plantar flexion. Sensory system testing involve pinprick and light touch score in the Asia impairment scoring. Initial management consists of pressure sore management, DVT prophylaxis, cardiac and pulmonary monitoring, nasogastric tube, fluid management, painkillers, care of the cervical spine, X-ray examination, standard AP lateral, oblique and flexion extension views if necessary, MRI scan and CT evaluation if necessary. Atlas fractures can be: 1. Posterior arch fracture, 2. Anterior arch fracture, 3. Jefferson fracture, which is burst fracture involving anterior and posterior arches, 4. Transverse superficies fracture, and 5. Lateral mass fracture. Treatment: stable fractures of the atlas, orthosis like halo vest will do the job. Jefferson fracture may need fixation if lateral mass displacement is more than 6.9 millimeters. Fusion involves occipit to C2 fusion in atlas injuries. Atlantoaxial subluxation. Neurologic injury is unlikely if there is associated dense fracture. Normal atlanto-dense interval is 3 mm in adults and 4.5 mm in a child. Treatment: halo immobilization. Residual ligamentous instability may need C1, C2 fusion. Galli's posterior fusion is popular for these injuries. C2 fractures. Anderson and D'Alonzo classification of odontoid fractures. Type 1 is fracture of the tip of the dens. Type 2 is fracture of the base of the odontoid, 20% rate of non-union in this type of fractures. Type 3 is when there is a fracture into the body of the C2. Treatment: all types can be managed in halo immobilization. Posterior fusion C1 or C2, C1 and C2 can be an option. Anterior transoral screw fixation of T2 odontoid fractures may be necessary. Hangman's fracture. Hangman fracture is traumatic spondylolisthesis with bilateral pars fractures of the axis. Levine's classification of Hangman's fracture is type 1, minimally displaced; type 2, when the displacement is greater than 3 millimeters; type 3 is when the fracture is associated with unilateral or bilateral facet dislocation of C2 on C3. Treatment: halo vest for type 1 and 2 lesions. Type 3 will need open reduction and internal fixation if close reduction fails. Occipito-cervical dislocation. Powers ratio defines the relationship between the occiput and upper cervical spine. Greater than 1 is anterior dislocation and less than 0.8 is posterior occipital dislocation according to Powers ratio. Treatment is posterior occipito-cervical fusion. Atlantoaxial rotary subluxation is classified by Fieldings as type 1, subluxation with odontoid acting as a pivot, no anterior displacement; type 2, subluxation with one of the two lateral processes acting as a pivot, anterior displacement 3 to 5 millimeters; type 3, rotary fixation with anterior displacement more than 5 millimeters; and type 4, rotary fixation with posterior displacement. Often identified in children who have had minor trauma or upper respiratory tract infection as precipitating factor. Treatment is traction and reduction followed by immobilization in halo vest. If unsuccessful, open reduction and internal fixation is carried out. Subaxial cervical spine injuries are classified by Ferguson and Allen. Number 1, compression flexion injury; 2, vertical compression injury; 3, distractive flexion injury; 4, compressive extension injury; 5, distractive extension injury; and 6, lateral flexion injury. 5 categories are described in brief here. First category is isolated posterior element fracture, may be a flexion type and is also called Clay-Shaw-Lewis injury. It can also be extension type fracture. Initial management is halos west. Open reduction and internal fixation may be necessary. Number 2, compression fractures are usually wedge compression injuries. Vertebral height less than 30% is indicative of unstable injury and needs internal fixation. Third category for discussion here is burst fractures. Initial management in burst fracture is cervical tongue traction. Indications for surgical fixation are loss of vertebral body height, retropulsion of the fragment with neurological deficit, kyphotic angulation, and posterior element injuries. Surgical treatment involves anterior decompression, corpectomy with strut graft and stabilization. Fourth group is teardrop fractures. Management depends on severity of subluxation, extent of bony injury, and ligamentous injury. If posterior ligamentous injury is unrecognized before intervention, postoperative kyphosis may develop. Fifth group, facet subluxation, which may be unilateral or bilateral. Bilateral typically have more than 50% anterior listhesis. Initial management of cervical tongue traction to reduce the dislocation should always be preceded by MRI scan. Unilateral facet dislocations are more difficult to reduce and may need 80 to 100 pounds traction. After reduction, varieties of posterior stabilization techniques are described. Thoracic and lumbar injuries. Categories are 1, compression fractures; 2, burst fractures; 3, flexion distraction injuries; and 4, fracture dislocations. Number 1, compression fractures. Compression fractures are often seen in the elderly after minor trauma. Bone scan is a very useful tool to rule out metastatic lesions. Management depends on age of the patient, location of the injury, kyphotic deformity, and posterior column distraction. Indications for surgical intervention are unstable injury, unacceptable kyphotic deformity, or progressive neurological deficit. Number 2, burst fractures. Anterior and middle columns are involved, often with retropulsion, bony fragment into the spinal canal. Treatment in neurologically intact burst fractures is non-operative if minimum kyphosis is present, or if bony retropulsion is less than 50% of the spinal canal without progressive neurological deficit. Treatment is controversial in neurologically intact patients with more than 50% of compromised canal. Conservative treatment should be stopped or abandoned if associated cauda equina or progressing neurology in this group of patients. Indications for operative treatment in burst fractures are A. All three columns involved with subluxation of the vertebrae. B. Significant kyphosis. C. Canal compromise more than 60%. D. Polytrauma with associated injuries. E. Thoracolumbar junction or lumbar spine injuries where kyphosis is poorly tolerated. And F. Progressive neurology. Treatment in neurologically involved patient is focused around decompression of the spinal cord, thecal sac, and nerve roots, almost always accompanied by partial or complete corpectomy with instrumentation. Strut grafting is often used. If burst fracture is highly unstable, anterior and posterior stabilization is carried out. Stabilization makes nursing easy. Number 3. Flexion distraction injuries, also called chance injuries. Chance fractures are typically 3-column injuries with fracture propagating through the bone. Treatment: if fracture is through the bony elements, it can be successfully managed in hyperextension orthosis. If only osseous injury involved is pars interarticularis, it's best managed by open reduction and internal stabilization. Primary ligamentous or soft tissue damage needs open reduction and internal stabilization. Number 4. Thoracolumbar trauma in causing fracture dislocation. It's a significant energy applied to the spine, and forces may include flexion, distraction, extension, rotation, shear, and axial loading. Fracture dislocation of the thoracolumbar spine is extremely unstable injury, most commonly associated with neurological damage and best managed with internal fixation. Few words on sacral factors. High energy trauma in younger individuals, and it can also be as a result of minor trauma in elderly osteoporotic bone. Denise has classified these fractures into zones. Sacral fracture zones are: Zone 1, fracture is lateral to the neural foramen. Zone 2, fracture is through the sacral foramen, and this group is associated with 28% incidence of neurological deficit. Zone 3 fractures involve central canal, and this group is associated with 57% incidence of neurological damage. Zone 3 often requires operative decompression. Tumors of the spine. Broad groups are benign or malignant. Most common tumors of the spine are metastatic tumors. Benign tumors of the spine are mainly osteoblastomas and osteoid osteomas involving posterior elements. Other benign tumors which may be seen in the spine are aneurysmal bone cysts, giant cell tumor, hemangiomas, and eosinophilic granuloma. Benign tumors of the spine commonly present with pain and scoliosis. Treatment of benign tumors. Investigations and intriguing staging for benign tumors is always carried out. Excision of the tumor depends on the location for most of the tumors, and internal fixation depends on the stability of the spine after excision. Radiation up to 30 to 40 C gyri are given for aneurysmal bone cyst and hemangiomas. Complications of benign tumors are mainly three: scoliosis, recurrence, or malignant transformation. Let's look at malignant spinal tumors. Most common are metastatic deposits. 80 to 85% involve anterior column, 50 to 75% in the thoracic spine, 5 to 20% will develop neurologic deficit. Breast, lung, and prostate account for majority. Biopsy is done to confirm the diagnosis. CT-guided percutaneous needle biopsy is a useful technique. Treatment is mainly palliative. Goals of treatment are pain relief, structural compromise, avoid or improve neurological deficit, and to improve quality of life. Available modalities are radiation, chemotherapy, hormonal manipulation, and surgical decompression with instrumentation. Beware of excessive bleeding in thyroid and renal cell malignancies, and consider preoperative angiography and embolization in these situations. Often, combined anterior and posterior reconstruction will be necessary after excision of the tumor. Expected life expectancy is an important factor to consider while deciding on the type of internal fixation after excision of the tumor. Result of stabilization is quite good in terms of pain relief and neurological recovery for metastatic bone disease. Degenerative disorders of the lumbar and thoracic spine. Back pain can be due to various factors. Number 1, discogenic pain may be due to A, free nerve endings in the outer layer of annulus fibrosus and within the longitudinal ligaments. B, changing composition of the disc leads to fragmentation and fissuring of the annulus. C, asymmetrical radial tears of the annulus are more likely to be painful. Number 2, facet joint pain. Each facet joint receives innervation from two spinal levels. Facet joint pain is difficult to localize, often increases on extension. Number 3, nerve root pain may be due to hypertrophied posterior element, herniated disc, or spondylolysis and spondylolisthesis leading to A, alteration in intraneural blood flow, B, problems with exoplasmic transport, and C, inflammation around the nerve root. Number 4, muscle-induced back pain. Number 5, referred back pain. Number 6, dorsal root ganglion pain. Number 7, sacroiliac joint pain. Sacroiliac joint pain is tested by stress test of SI joint. They are A, Patrick's test, also known as Faber test. Faber stands for flexion, abduction, and external rotation test. B, Gaines length test is extension of the hip on one side while the other hip is flexed. C, pelvic compression test for sacroiliac joint pain. Number 8, piriformis syndrome presenting as back pain. And lastly, number 9, rest of the rare causes are classed under back pain due to miscellaneous sources. Investigations for back pain are plain radiography, blood investigations for inflammatory arthropathy, CT scan for spondylolysis, myelography if necessary, magnetic resonance imaging, nuclear imaging, discography, injection studies, electrodiagnostics, and most important, psychosocial testing. Treatment. Mainstay of back pain management are conservative measures. Mackenzie's system of exercises are directed towards maintaining a position of comfort in the spine and extension exercises. Heat treatments, ultrasound, chiropractic manipulations, tractions, lumbosacral braces, NSAID and back schools are some of the other available modalities. Surgical treatment options are: number 1, discectomy. Thoracic discectomy should always be an anterior discectomy. Number 2, discectomy with fusion. Number 3, discectomy, fusion and instrumentation. Vast majority of lumbar disc degenerate disease with acute back pain and or sciatica improve with time without surgery. Lumbar disc herniation with progressive neurologic deficit, particularly cauda equina, need urgent disc decompression. Lumbar discectomies can be open discectomy, percutaneous discectomy, laser discectomy and endoscopic removal of herniated disc fragments. Complications: wrong level surgery, dural tear and nerve root injuries. Let's look into spinal stenosis. Arnaldi has classified spinal canal stenosis as: number 1, congenital or developmental stenosis as in achondroplasia. Number 2, degenerative can be central or lateral foraminal stenosis. Number 3, post-spondylolisthetic stenosis can be degenerative or isthmic spondylolisthesis. Number 4, miscellaneous group of spinal stenosis, for example Paget's disease or spinal tumors. Degenerative spondylolisthesis most commonly occur at L4, L5. Clinical presentation typically has pain and pain relief on flexion. Differential diagnosis must include neurologic claudication and vascular claudication. CT scan is done to measure the spinal diameter and MRI scan is done to look for the highest level of spinal cord compression. Treatment: non-operative treatment is not always successful. Surgical options for spinal stenosis are: number 1, decompression by laminectomy, preserving most of the facet joint. Number 2, laminectomy with lateral recess decompression, which may need facetectomy, in which case instrumentation will be necessary. Let's discuss degenerative spondylolisthesis. Most common level is L4, L5. Nerve root is often compromised. Surgical treatment options for degenerative spondylolisthesis are: number 1, decompression alone. Number 2, decompression with in situ fusion. Number 3, fusion with instrumentation. Number 4, decompression, posterior instrumentation and fusion along with anterior surgery to help restore sagittal alignment. Next topic is degenerative diseases and disc disorders of the cervical spine. Cervical spondylosis. Pavlov's ratio has become a standard parameter to diagnose clinically significant cervical canal compromise. This ratio is calculated by the size of the canal divided by the AP diameter of the vertebral body. Greater than 1 is normal. Between 1 to 0.8 indicates relative stenosis and less than 0.8 denotes absolute stenosis. Differential diagnosis includes intra and extraspinal tumors, entrapment syndromes of median, ulnar and radial nerves, thoracic outlet syndrome, brachial plexus and shoulder disorders. Diagnostic investigations are plain X-ray studies, CT scan, MRI and discography. Treatment can be conservative or surgical. Conservative therapy for pain without radicular symptoms consists of isometric neck strengthening exercises, emotional and physiotherapy support, trigger point injections and non-steroidal anti-inflammatories. Factors to consider before surgical intervention for failed conservative means are: number 1, disc herniation, 2, cervical alignment, 3, significant arm pain not responding to conservative means. 4. Neurologic deficit with radicular pain. 5. Proper corresponding imaging studies. Approaches and techniques for cervical spondylosis are: number 1, anterior surgical approach using Smith-Robinson technique or Clovered technique. Number 2, anterior cervical disc excision without fusion. Number 3, posterior surgical approach. 4, keyhole foraminotomy. 5, hemilaminectomy. Cervical spinal stenosis. General agreement is that 13 millimeters or less sagittal diameter of the spinal canal from C2 to C7 is abnormal. Pavlov's index or spondylolisthesis index can be measured. Most of the literature on natural course of the cervical spondylotic myelopathy suggests that more than 50% will progress and deteriorate. Surgical treatment options are: A. Laminectomy at one or more levels. B. Expansive open door laminoplasty. C. Anterior cervical discectomy and fusion for multilevel pathology. Ankylosing spondylitis of cervical spine. First change is seen in sacroiliac joints. Next, skeletal changes appear at thoracolumbar, lumbosacral and mid-lumbar areas. Bamboo spine is pathognomonic. Common pathologies in the cervical spine affected with ankylosing spondylitis are: 1. Atlantoaxial subluxation. 2. Subaxial fracture deformity with instability. 3. Occipito-atlantal destruction. 4. Fixed kyphotic deformity. Operative stabilization is required for these conditions. Rheumatoid spondylosis of the cervical spine. Pathologies in rheumatoid cervical disease are: number 1, atlantoaxial subluxation. Number 2, occipito-atlantal and atlantoaxial joint destruction with cranial settling. Number 3, subaxial subluxation. Ranawat classification of rheumatoid neurologic deficit: Class 1, pain but no neurodeficit. Class 2, subjective weakness. Class 3, objective weakness with long tract signs. Class 3 is subclassified as A. ambulatory and B. non-ambulatory. Frankel's grading scale can also be used. Radiological assessment: number 1, atlantoaxial subluxation, atlanto-dense interval more than 3.5 to 4 millimeters is abnormal. Number 2, cranial settling, also known as basilar invagination. McGregor's line is the line drawn from the hard palate to the caudal surface of the occiput. Basilar invagination is considered present in men with the tip of odontoid 8 millimeters above this line, and in women when it is 9.7 millimeters above the McGregor's line. Ranawat's index is the minimum distance between the line from the center of the anterior arch to that of the posterior arch of the atlas and the center of the pedicles. Normal values: 15 millimeters in females and 17 millimeters in males. Posterior atlanto-dense interval less than 14 millimeters is abnormal. Number 3, subaxial subluxation. Canal size less than 14 millimeters is abnormal, and less than 13 millimeters needs surgical arthrodesis.